Ladies and gentlemen, welcome to the CardioTube interview on antiplatelet therapies for non-cardiac surgery. Welcome to the CRT 2020. My name is Jolanta Silematula. I'm professor of cardiology from Medical University of Vienna. And today I'm very pleased to welcome Professor Jung Sun Kim from Seoul, Korea, who is a distinguished expert on pharmacotherapy, on structural and coronary interventions. And today we will discuss the topic of mono and dual antiplatelet therapy for patients undergoing non-cardiac surgery.
Yeah, thanks for...
So, do you use any algorithm for patients who would undergo urgent or semi-urgent non-cardiac surgery and having recently been implanted drug-eluting stents?
Yeah, that's right. Thanks for a nice introduction. It's my great pleasure to join this symposium and give some presentation in this nice meeting. So today I will give some presentation regarding some antiplatelet strategy before the non-cardiac surgery in patient with second-generation drug-eluting stents. So in this study from 9 medical centers from Korea, we enrolled around 3,500 patients.
Wow.
Yeah, who received the drug-eluting stents, second-generation drug-eluting stents, and underwent non-cardiac surgery at the same hospital.
Wow, it's a really representative sample size.
Yeah, that's right. Yeah. Also, you already mentioned regarding urgent surgery is around 10% of patient. Most of patients usually perform the non-cardiac surgery in routine practice. Yeah.
So what's the main result of the study? What's the conclusion?
This study is just an observation study, not randomized study, according to the antiplatelet strategy. So first finding, one of the main findings is half of patients we can discontinue the antiplatelet therapy before non-cardiac surgery in patients with second-generation drug-eluting stents. The other one is even though we discontinue the antiplatelet therapy, there is no significant increase of NACE, net adverse clinical event outcome, and major adverse clinical outcome, as well as major bleeding was not significantly increased.
So how many patients were stopped the DAPT, or at least probably single antiplatelet agents? They were probably still operated with aspirin.
Actually, among 3,500 patients, around 800 patients continued the aspirin.
Yes.
And 1,800 patients discontinued all
DAPT.
antiplatelet agent
So
at least one day.
Did you have any patients underwent surgery on DAPT?
Actually, I think around 700 patients.
So how many percentage was that?
Actually, it's around 25%. Yeah, percent was underwent.
So how was the reoperation for major bleeding in those operated on DAPT? Because there are many meta-analyses, also one performed by my research group, showing that if you operate patients on DAPT, also for non-cardiac surgery, the risk for reoperation for major bleeding is twofold higher. How was that in your study?
Yeah, but in this study, I think there is no significant difference between the different strategy of different antiplatelet strategy.
So what does it mean? So what's the conclusion if there's no difference?
I think, but there was some different clinical setting. For example, in most of study, patient with DAPT has a shorter duration, from the PCI to the non-cardiac surgery. That's the reason why they continued DAPT compared to the other population. And the other thing is also we should think about the different risk factor, especially ischemic risk profile in each patient. So when we adjust all risk profile, you mean that because of there is some different baseline characteristics, then there is no significant difference among that group.
So how would you What do you believe about patients coming with non-STEMI or and they have an indication for coronary angiography? Would you pre-treat those patients, already with doubt? Because there's, this discussion. Some of them won't have actually acute coronary syndrome, and some of them will have an indication for like CABG. I know it's still a coronary intervention and non-cardiac surgery. But what do you think about that? Should we prolong or should we not? Should we wait?
Yeah, for this issue is somewhat different. Yeah, for the antiplatelet issue. But actually, in real clinical practice, if patient come to the hospital need a non-cardiac surgery, especially for the cancer surgery, then we recommend two options. One is CABG for the triple vessel disease, left main disease, and extensive coronary artery disease. At that time, we usually recommend for some bypass surgery. However, sometimes we encounter some single vessel disease or just two vessel disease is covered with one or two stents. Then we recently recommended some very recent some stent. For example, biofreedom study.
Like the short
duration. Short-term depth. Yeah. Actually, especially for some clinical presentation, ACS versus stable angina. For the stable angina is currently recommended. Just 3 months later, we can just continue aspirin. During the non-cardiac surgery. Otherwise, I think it's possible after 6 months, in my personal opinion, we can discontinue all antiplatelet therapy when we evaluate the patient of the risk profile, especially some complexity of the stenting or sometimes some bleeding risk of the surgery. But for the acute coronary syndrome, it's somewhat different scenario.
But you can still have have a non-STEMI and then during the first days have an indication for urgent non-cardiac surgery. What do you think about use of kangra law in terms of bridging? Yeah,
that's right. It's a very important point. It is not available in Korea, but I think it is very useful draw for me. To bridge, to antiplatelet some activity.
Because I think the bridging dose, which is much lower than actually the dose which we use for acute coronary syndrome. And we have one nice study, but still I think in the clinical practice, not so many people would use that.
Yeah, that's right. I agree.
So, Dr. Kim, thank you so much for sharing your expert opinion on that topic. And thank you very much.
It's my great pleasure, to having me this kinds of
and thank you very much for joining us for CardioTube at CRT 2020. And I hope you will enjoy the interview.